And then we look for things like protein leak in the urine. And if he's got protein leak, then the first medication which we actually stole from cardiology is ACE and ARBs.
These medicines not only lower the blood pressure, but they also improve how long a patient lives for.
And the next one is the one which is in the news a lot, Ozempic. Now, I've seen a lot of health influencers saying that Ozempic is not good for you. Well, I agree. If you're taking it before a wedding just to lose weight, it's not good. But if you're taking it for kidney disease or heart disease, where the first three line of medications have worked, but still you've got excessive protein leak or your risk of heart disease is high, then I think it is a good medicine. The reason why there are so many new medicines coming up for kidney disease now is that earlier the trials used to focus on seeing if we can prevent dialysis. So now they're looking at something else. They're seeing if we can reduce proteinuria as an endpoint in trials. So that's why new medicines are getting approved much sooner.
Welcome to Delhi Belly, a series of conversations around preventative health for people of Indian origin. Again, today we're joined by Dr. Arjun Sabharwal, who's a kidney doctor with experience working in India and the UK. And so again, we're going to use his expertise to dive deep into, cardio-renal syndromes and really thinking about how far we have come over the last few decades. Because even when I went to medical school around 2010, things have come along a whole way. We've got a load of new treatments. We've got new treatment options. And there's a lot of optimism when I go to conferences now about the different things we can do. And so I think it's important for people who have friends, family members, or even themselves who have kidney conditions or heart conditions, we try and share that message so people are aware of the options that are out there.
Yeah, definitely. Thank you for having me again. Like you said, there are so many more treatments now for kidney disease, which were not there before. And this is like in cardiology, many years ago, there was so much new invention, so much new treatments. They're saying this is the new cardiology era, where in kidneys or nephrology, we are getting a lot more treatments as compared to before.
Okay. Good. I mean, great. Let's dive straight into that with another patient story. So we have a 42-year-old gentleman who, again, has been seeing his doctor regularly. He's been doing very well, leading an active lifestyle, but he has diabetes. This time when he goes to see his doctor tells him that his kidney function is abnormal and he gets very upset. The doctor asks why, and he says, well, because when my father was in his 40s, around in 1980, he developed diabetic kidney disease as well. And soon after that, he died from it. And so this gentleman, of course, understandably is very upset. But I think this is a good opportunity for us to try and contrast how things were in the 1980s and how things are for a patient with kidney disease today.
So in 1980s, in a few years, they'll just talk about dialysis because dialysis was the only treatment back then, along with some new medications which were coming up. But now we've got so many new trials, so many new advances. So just to take an example of this patient, we would first thing always is diet and lifestyle, right?
Okay.
We'll tell him to fix his diet, get his diabetes under control, start exercising. And then we'll look for things like protein leak in the urine. And if he's got protein leak, then the first medication which we actually stole from cardiology is ACE and ARBs, which are your telmisartan and ramipril, which you use widely in cardiology, isn't it?
Yeah, I mean, ACE inhibitors have been used for decades, and we've got a lot of good evidence that for patients with heart failure or who've had heart attacks, that these medicines not only lower the blood pressure, but they also improve how long a patient lives for. And that's because they interact with something called the renin-angiotensin system, which is, again, like a thermostat in the body that controls how stressed the body can be, to put it in very simple terms. And so it helps to try and control that and control the fluid balance. And so understandably, if it takes some of the pressure off the heart, it probably takes some of the pressure off the kidneys.
Yep. So it reduces the pressure in the kidneys, which in turn reduces protein leak. And like we said before, protein leak is directly linked to kidney disease. If you've got more protein leak, your risk of having kidney failure increases and the speed of having kidney failure increases. So the whole aim is to stop or reduce protein leak. The other thing about ACE inhibitors is that when it started, it actually causes a rise in your blood creatinine levels. So patients panic and they think that it's causing their kidney function to drop. But actually, that's how the medicine works. And it's absolutely normal. Even all major guidelines say that a rise up to 20% of creatinine is normal. So we shouldn't stop it. We should actually continue it unless they're getting some side effects.
I mean, I think this is important for any patient who has heart problems or kidney problems to know, because if you have fragmented care, which means let's say you go to one hospital for your kidney care, one hospital for your heart care, you may well get started on an ACE inhibitor by your kidney doctor. And this patient may well have that. And then when he goes to see another doctor, they will do the blood test, see his creatinine has gone up, and they will stop the medicine.
Yeah.
And so sometimes the patient is best placed to say, hold on, this is what I was told to expect. In an ideal world, the system would be better connected. The doctors would be able to communicate and share information. But sometimes the patient has to be their own advocate and understand that this is what's going on.
Yeah, that's why you need to subscribe and watch this podcast so that you learn more about these medicines and you get more knowledge about kidney disease. Because like we were discussing before, patients know their disease best. If you're going through something, you'll be able to manage it the best, obviously under the guidance of doctors, but it's important that you also know about your condition.
Yeah. So ACE inhibitors in cardiology, at least, have been around for decades. In cardiology, we've had a lot of newer treatments for managing chronic heart failure. And these treatments may not directly change the heart shape, but their biggest effect is on how long patients live for. So these are what we call disease-modifying drugs. And so the way I like to think about it is in diabetes, you can have treatments which will bring down your sugars, but you will then also have treatments which will help patients with diabetic kidney disease just live longer. So these medications are newer, that are being introduced in cardiology, certainly in the last decade, and I think in kidney medicine also in the last few years. And we're seeing the guidelines across the world change to say, hold on, these medicines are helping patients live longer, and we have got trial data from thousands of patients that show these substantially change the way or how long patients live for and their quality of life. So they should be introduced when a patient has that diagnosis.
Yep, definitely. And the reason why there are so many new medicines coming up for kidney disease now is that earlier the trials used to focus on seeing if we can prevent dialysis. But we know that kidney disease is very slow. It takes years till patients reach that stage. So now they're looking at something else. They're seeing if we can reduce proteinuria as an endpoint in trials. So that's why new medicines are getting approved much sooner, which is a good thing. We know proteinuria causes kidney damage, and changing the endpoint to protein leak rather than dialysis means more and more pharma companies can invest in these trials because the trial duration is shorter. So just to go to another medicine that is used for both diabetes and the heart is SGLT2 inhibitors, such as dapagliflozin and empagliflozin. And the DAPA CKD or the EMPA CKD trial showed that these drugs reduce protein leak, reduce the progression of kidney disease, and also reduce the risk of heart disease, which is the three things that we see in kidney patients.
Yeah, so I guess it makes sense then. The story makes sense because if you are helping reduce the amount of protein leak, you may well be altering that physiology. And so that would make sense to understand why that kidney disease would progress less slowly and why you're seeing these improvements in harder endpoints of less cardiovascular events, so less heart attacks, less heart failure, and less death when you look at all that together. So we're seeing good data coming out around these SGLT2 inhibitors. And this is why I think cardiologists and renal doctors are working more closely together, because it is becoming more and more apparent that these medications work in both chronic heart conditions and chronic kidney disease. And so these medications help improve both, potentially, if you've got both conditions. But certainly when I see a heart patient, when they've got kidney disease, it makes everything a lot harder. Let's say they've had a heart attack, it limits potentially what sort of tests we can do on them because of their contrast risks. It limits the medications we can offer them or the doses of medications we can offer them, and it makes things harder. So to have a treatment that can help manage heart and kidneys at the same time certainly is a big step forwards for patients who often have the two.
Yeah, definitely. And the reason we tell all patients is to have blood tests done, urine tests done early, is because all these medications work in a certain range of their kidney function or their EGFR. So if you're coming to us with EGFR very, very low, less than 15, less than 20, then the options are very limited. So that's why we need to pick these patients up early and start these treatments early so that we can prevent them from reaching end-stage kidney disease. For example, dapagliflozin has been approved if EGFR is more than 20.
Okay.
So some new trials are seeing if you can use it in patients who are on dialysis or if their EGFR is very low. So we have to wait for those trial results. Similarly, another medication which is used for both heart and kidneys is Finerenone, and the trial for diabetic kidney disease with Finerenone showed that it significantly reduced proteinuria and reduced the risk of heart disease. And you're using it in heart failure too now, Finerenone.
Yeah, only in the last year or so, the big trials have come out and reported again improvement in these harder endpoints. So less heart endpoints. So patients having heart problems that cause them to die or go into hospital from a result of these new medications. So just in the last few years, these medications that are working for kidney disease have also been shown to work for the heart. So again, another reason why closely working together is really important.
Yeah, definitely. And then the next one is the one which is in the news a lot, Ozempic or GLP-1 analogs. Now, I've seen a lot of health influencers saying that Ozempic is not good for you. Well, I agree. If you're taking it before a wedding just to lose weight, it's not good. But if you're taking it for kidney disease or heart disease, where the first 3 line of medications have worked, but still you've got excessive protein leak or your risk of heart disease is high, then I think it is a good medicine. Definitely in someone who's trying to lose weight, has got poorly controlled HbA1c or diabetes, and has got heavy proteinuria. What is your experience of using GLP-1 analogs in heart failure patients?
Yeah, I think if the patient is overweight, obese, and meets that weight criteria, then they certainly will benefit from these GLP-1 medications in terms of improving their heart conditions. Now, this is still in the early stages in the heart world, in the sense that we know that there are some types of heart failure where obese patients do better on them, but the data is coming. And so it is, again, an exciting time because we're finding that there's a lot of positive data. Now, when patients come into the clinic and they are overweight, we know that the benefits for them, regardless of their heart disease, if they are obese, are significant in terms of losing that weight and reducing their risk of diabetes. And so there are reasons beyond just the heart and the kidneys for why these medications might work. But you're right. I think it sort of makes sense to me that if you can reduce the amount of strain and stress on the body, we're talking about the pressure on the heart and the kidneys. And so if you are carrying many, many kilograms of excessive weight, we've talked in previous episodes about the different types of fat and the brown visceral types of fat, which can really increase your risk of diabetes and complications. And so if there's a medication that reduces that, you may be taking off some of that pressure on the heart and kidney. So again, to me, it makes sense, but I'm waiting to see a bit more data before we give it to all different heart patients.
Yeah, because obesity itself is a disease, right? And if you've reached a point where you're unable to lose weight, you're getting end organ damage because of obesity, then I think GLP-1 analogs is a good option. Obviously, lifestyle plays a role because once you stop these medications, the weight does come back.
Mm-hmm.
So you have to fix both your diet, exercise, along with medicines.
Yeah. And I think one thing to tell this gentleman here who's sitting in front of us, or any patient who is given a diagnosis of kidney disease or heart disease today, who's worried about how things were in the past, is this idea that we are picking up conditions earlier, as you were saying.
Yeah.
Our thresholds for what is considered hypertension are lower than what they were 40 years ago. Our threshold for what's considered diabetes, what's considered kidney disease, what's considered heart failure are all changing. They're all much earlier. And so we're seeing more people qualify as having heart disease or kidney disease. And that's because we know that, as you said, starting these medications earlier, sooner, before the kidneys have shown really overt signs of serious failure, means that we can potentially avert that and intervene at an earlier stage. So just because you have a label of kidney disease, you may well have it at an earlier stage than what your father or grandfather was given 40 years ago. So again, there are reasons to be more optimistic today with these conditions because we are finding it sooner, treating it more aggressively, and that is translating into improved quality of life.
There is definitely hope for kidney disease patients now, and I always tell them that you have to stay positive. Like you said, in 1980s, there were no treatments for kidney disease, but now we've got so many treatments that we want to prevent dialysis. We don't want you to go to the stage where you need dialysis. So trust science, trust your doctors, and look out for this space because a lot more medications will be coming for kidney disease soon.
Great. And if you wanted to stay up to date, please follow and subscribe, and we will bring you all the data as it comes out. Thanks very much.
The wellness and supplement industry is 3 times bigger than the pharmaceutical industry. I've read a lot about omega-3 fish oil, and I've also started taking omega-3 fish oil simply because few people should be taking it. For example, if you've got history of heart disease, high cholesterol, history of diabetes, then you should be taking omega-3 fish oil. That's what the studies are showing.
Now, there have been a number of studies looking at thousands and thousands of people with diabetes, without diabetes, with high risk of heart disease, who've had previous heart disease, and trying to understand what type of fish oil they should take and how much.
There was a trial recently last year on dialysis patients. We know dialysis patients have higher risk of heart disease.
Yeah.
And they gave the same dose, 4 grams of omega-3 fish oil. It's called the PISIS trial, and it showed that it reduced the risk of heart attacks in patients who took omega-3 fish oil. And that's why I think as a kidney doctor and even as a heart doctor or any doctor, it is important to talk about what supplement actually works and what doesn't work.